we've seen over and over from an access standpoint, how that makes a difference then, especially when you're looking across racial disparities, ethnic disparities, geographic disparities, that having that person who can break down those barriers then is a great equalizer in that process.
You're listening to the Oncology Nursing Podcast, where ONS Voices talk cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast.
Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Jaime Weimer, Manager of Oncology Nursing Practice at ONS. And today we're talking with Bonny Morris, Senior Director of Patient Navigation at the American Cancer Society based in Atlanta, Georgia, to discuss patient navigation in cancer care. As a reminder, you can earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. Thanks so much for joining us today, Bonny, and welcome.
Thank you so much for having me. Excited to be here.
So broadly speaking, I think the term navigation is not new for oncology nurses, but I do think it's important, especially as we start off our discussion today, to create some clarity on how that role can be different. So to start off, what is patient navigation and how does that intersect with nurse navigation?
Absolutely. And you're correct with the concept of navigation has been around a long time. It's been 30 years of evidence building and research and practice to get us to this point. So when we think about just the general concept, it's the providing of resources, education, support, all working towards reducing barriers and improving timely access then to appropriate cancer care. So conceptually, that's how you would think about the term navigation. But then we have the PONCE standards, Oncology Navigation Standards of Professional Practice, which provide a formal definition and emphasizes first and foremost that the assistance is individualized and that this is based on where the person is in the cancer continuum, their specific concerns and barriers to care, and how the person providing navigation services can determine that, can assess for those specific needs, can go through a screening process to understand where that person is coming from, their cultural background, anything that may influence their cancer journey. And then when we're thinking about how it intersects with nurse navigation, that's really where the role delineation piece becomes so critical, because we want everyone working to the top of their licensure, right? And navigation can be done in a clinical fashion, in a non-clinical fashion, so provided by individuals with a clinical license and without a clinical license. And so when I was an oncology nurse navigator, it was really the education and the resources that I provided that had a clinical focus that then were applicable for my work. So I would talk with patients and families about their diagnosis, about treatment decisions, symptom management. And then when patients had non-clinical concerns, which many do, I would coordinate with a team of patient navigators who were not clinically licensed and instead then focus their services on addressing non-clinical concerns like transportation to said physical therapy, or, if I was working with a patient on that type of symptom management and that service then associated, but they had concerns about accessing that service. So it's really becomes a system of how clinical navigators or patient navigators can work together. And I know not all systems have both. It can be either one or the other, but for us, where I'm coming from in the system, having both and then the coordination really helped with our nurses, our social workers, all work to the top of their licensure and improve then the associated care, and the patient then benefits as a result.
I completely agree that as navigation has evolved, it always should be customized to the patient needs and sort of what the program, the community needs and the program needs of where that navigation is occurring. I definitely appreciate that now we have standards and competencies and things to also solidify and help clarify that delineation of how those roles can be complementary and sort of where they diverge. And I think that has been an important part. As you said, not all programs have that divergence. Sometimes it's just nurse navigation and they're trying to do all of those things, or perhaps maybe they're working with a social worker to pick up some of those non-clinical pieces. But I think, again, as you've said, there's longstanding research and data to help drive the legitimacy of this role. And so having some of those formalized documents to help create that clarity, I think is really important. And it's a very welcome addition to helping to set up these programs and structures at individual healthcare facilities.
Absolutely. It's a really exciting time, truly.
Absolutely. So you've mentioned that there is now evidence to support that, or maybe there has always been evidence, but it's growing and now being brought more to light. So what is that evidence? What does it say and suggest about the relationship between patient navigation and disparities in cancer care?
Yeah, absolutely. And to your point, so it's been 30 years in the making of building this evidence of how from the screening process, getting people into treatment quicker, maintaining that treatment. So you think about from the initial screening pathway, how we can make sure that people are diagnosed at an earlier stage, how then we're getting them into start treatment sooner so there's not a treatment delay to then impact on the cancer outcome, having a better survival rate with it, whether once they're in treatment, there's treatment adherence, these different measures that we've seen over time. So with treatment adherence, it's making sure that they're attending all their chemo appointments or radiation appointments, because then we know that has a clinical impact based on their treatment plan, that we're managing their symptoms along the way so that then they can stay in treatment to the best of the ability and then be able to either move into back from the oncology specialty care side of things into primary care, working with survivorship plans, how the navigator can support that process and that transition, as well as into palliative care, hospice care, how we can support across the cancer continuum. And we've seen over and over from an access standpoint, how that makes a difference then, especially when you're looking across racial disparities, ethnic disparities, geographic disparities, that having that person who can break down those barriers then is a great equalizer in that process.
Absolutely. And as I listened, it strikes me, it feels like earlier on in sort of the navigation or care coordination space that I feel like many times it was branded as like, oh, well, our healthcare system is so convoluted and broken that we have to put people now in these positions to help people navigate their way through it. And I mean, yes, I think there is still sometimes legitimacy to that claim, but I think care itself is complex. The medical space that we are, shuttling patients from appointments and specialists. And if they're not themselves, healthcare providers, then it's like a foreign language to them. We also see that now, not even outside of oncology, even though this is sort of, I think, where it really started. But now we're seeing just complex care navigation, other chronic illnesses that are just really complex and requiring lots of different tests and treatments and specialists, and just acknowledging that patients deserve someone to help guide them through this. As you said, barriers to care that are part of their kind of livelihood, lifestyle, environment where they live, but also barriers internal to the system that we acknowledge that the healthcare system is confusing sometimes. So I'm excited to see that it's now being recognized of this is just the right thing to do. This is what we have to do to make sure that our patients understand the care that's being recommended to them. And then we facilitate making sure that they can get that care in all the ways that you mentioned.
100%. I mean, it truly is a foreign language. And not only that, when you get hit with that diagnosis, it's like time stops. And even if the person that's delivering that news, they're trying to provide the best communication possible, but you just don't hear anything else. And you're overwhelmed trying to process everything and trying to just figure out what is that next step. When my dad was diagnosed with metastatic prostate cancer, I've been in the field for decades at this point. We're coming from a family that has a medical background, has experience in the healthcare system, having friends, having colleagues who are navigators or oncologists. And I feel like we have access to all these different people, expertise. It was still overwhelming, so even if you're in the system, there's just a lot of different things to consider, even with people. My dad's from a very rural area, and coming into the big city was a barrier for him. And how do you navigate that? How do you navigate the financial pieces? Like some of those things are going to be present regardless of how long or how experienced you are in the system. And it's just complex. Exactly what you said. It's just complex. And, I think back to one of the first so prior to being an oncology nurse navigator, I was inpatient in critical care bone marrow transplant. And the first patient I did end of life care for, it was something that will always stick with me because she shouldn't have been there. She shouldn't have been there in the first place. And it still makes me mad when I think about it because she was so young, coming from a rural area, delayed diagnosis, delayed treatment. And it was really around just a fear of the unknown, a fear of the system, of challenges with transportation, all these different barriers that we read about in the literature, but seeing it in real life and I'm just mad. It's something that we have to be able to fix. And I'm super passionate about that. How do we make that story different for other people? And that's then what we've been able to see with implementing navigation and going from this person should have had a different outcome, had a different story to tell, and to the person who's driving from 3 hours away from West Virginia to North Carolina to receive care, car breaks down. We're all working together to then help her have access to transportation to get her to that surgery that she was going to refuse, saying, I can't get there. I can't do it. I'm going to have to just opt for chemo back home. And we all worked together to then first find local transportation through a local faith-based organization to get her to another city that was closer, to then get her on a bus that could then bring her within range of other transportation options because, we couldn't get an Uber to go out there. But then she was able to have that surgery that then meant a completely different clinical trajectory. Those are the types of stories that stick with me and why I continue to be super passionate about how impactful navigation can be.
Absolutely. That's a great example, just really demonstrating the impact. And you mentioned earlier that navigation happens along the entire continuum. And that can be, as we've already delineated, the patient navigation, non-clinical, or even nurse navigation and clinical. I mean, you think of all the opportunities for someone's care trajectory to get off track. It could start at screening. Hopefully there is screening, and it can start there if the right results aren't communicated accurately and if the importance of follow-up or referral are not made. I mean, as you said, that starts out a totally different direction than what would be ideal if they were given the right information, guided and supported to start that journey of leading to true diagnosis. And so it is important to consider, I think, classically, and probably most often, we do see navigators in the space of oncology. So once you're diagnosed, you might have a navigator, hopefully. But I think the importance can be emphasized enough of navigators on both ends of that spectrum are just as important, but just have a very different kind of domain of influence that they can work with depending on what phase of the care continuum that patient is in.
I think you bring up a good point, though, is they might have a navigator. And that question mark in that sentence is I just want to underscore that is that it's not guaranteed. You can go in one system or on one particular day. It's, it just depends. I think each system has it set up differently. There are models, but they're not standardized across all healthcare facilities. And so you might not have a navigator. And then what?
Absolutely. And given the evidence that it's so beneficial, it would seem like everyone would have one, everyone would want one. So what are some of the barriers that you see in making that sort of a reality for every patient at every cancer center?
Up until this point, there's not been a sustainable way to financially support navigators. So often systems would depend on philanthropic donations or funding associated or grant space. I know I would get excited if we applied and received a grant that then was for 2 years for a breast navigator, for example. It would always be very specific. Or it was just built in, the case had been made and built into the operational budget to then internally fund a navigator, or if you're lucky at, a couple navigators or what have you. But the financial sustainability piece has been hard. And I think this is why this time is now so exciting and historic, is because we have a more robust way to be able to reimburse for navigation services that could then provide the financial support and backing for those positions. Before the release of the Centers for Medicare Physician Fee Schedule that was released on January 1st, we had principal care management codes that I question how much were really being fully utilized for navigation across all healthcare systems. I think there was some miscommunication and conceptions about how those could be applied. And so we're learning about that now and trying to figure out how we can build those in for the clinical side of navigation. But then now we also have the non-clinical side through principal illness navigation codes, SDOH screening codes, community health integration codes. So that's a really exciting change that now will help build the sustainability for having navigation across the board so that it's no longer a nice to have, but it's a need to have. And that's what we've seen. It's a need to have, and it can be now an absolute that it can be within a system, within a practice.
To me, this ties into the more global question of just nursing services in general and how they are incorporated into health systems budgets. It's sort of the room and board. It's just because we don't generate revenue, quotes on that. It's a part of a bigger, I think, discussion that needs to be had. But this is definitely progress in the right direction. As you said, there already were some abilities for clinical navigation to have some minor reimbursement for those services. But now this expands it to even the non-clinical services. So let's dive into that just a little bit more. So as you mentioned, it's the Centers for Medicare and Medicaid Services final rule for the 2024 Medicare Physician Fee Schedule, which is a mouthful, and many nurses might not have to live in that space, and they're lucky for it. But in terms of reimbursement for navigation for patients, what does that mean? And what does that mean for oncology nurses?
Yeah, so I think it's important to think about two components of this. So there's the person providing the navigation services, and then there's the billing practitioner who then is submitting the codes that allow for the reimbursement. And for this rule, both are important and both are relevant to principal illness navigation or, any of the new codes related to navigation. I'll just lump them all together for now. Mm-hmm. So you have the person providing navigation services who may be an oncology nurse, it may be a community health worker, it may be a patient navigator, it could be an ambulatory nurse. So it's dependent upon the services being provided and not the title. And CMS is clear about that. And it describes within the final rule the different activities that can be applied and how they relate to then competencies that the person providing navigation services should either be trained or certified in. And so you have the person who's then providing the services, you have the billing practitioner who then, and they're providing these services incident to the billing practitioners deeming that the person is eligible for these services. So while the navigator is under the supervision of, it doesn't have to be done while the billing practitioner is present, but there's that very consistent connection and acknowledgement that this is part of the treatment plan. It's supporting the person's access to and ability to fulfill that treatment plan. And so to be able to start that entire process, the billing practitioner would go through, determine their eligibility based on the diagnosis of a serious illness. And CMS describes that definition that it's for Medicare only at this point. So that's another distinction. And we hope that it will continue to expand and private insurers will take this up. But this will be interesting from an implementation standpoint because it is a subset of the population, whereas that's not how we've typically subset navigation services. We've subset navigation services or triage or, based on an acuity score or a disease type or some other type of measure, like for Medicaid populations, maybe, or something like that. But this is different. So I think implementation around that will be interesting and something we want to continue to keep an eye on. So once the person's eligible, the person providing navigation services can then come in, do what they normally do from a navigator's standpoint. The training competencies that CMS lays out are all very, they're built upon the evidence. So they make sense. And so you're doing those services, you document that time spent. The provider then attests for that. that was done in accordance with CMS rule, then the reimbursement process happens. And so it, in theory, can work great, right? But it's when you get into the weeds of, okay, having those codes built, new codes added to your system, training people on being able to use them, training them on the documentation. It really, I think that there's going to still be some challenges in uptake. And that's what ACS is working on now is we have a training program to support. We have implementation programs that we're supporting that we've built out. And so it's really trying to be responsive to the needs of those who are boots on the ground implementing these codes. And how can we make it easier? Because we know that patients deserve this. So if we're able to now have this more sustainable pathway, let's make it easier to get to that point.
You already mentioned sort of anticipating some of the challenges that come with that implementation, even specific to billing. So can you talk a little bit about the principal illness navigation, or the PIN, and how that might be challenging to sort of introduce that to the institution for the first time?
I think one of the challenges that we're already seeing play out, both from an institutional standpoint, but also from the patient side of things, is that there is cost sharing associated and the consent process as part of that. And so you've got all these different workflow changes. And I don't want to make it sound scary because it's something that we can work through, and we will work through it, but they're just different touch points and considerations we'll need to consider. So for the patient consent process, it can be done verbally as long as it's documented that it took place, because there is that 20% cost sharing that the patient could receive a bill for if they don't have additional coverage for that. And I worry that that could increase disparities, truthfully, because it's going to be the subset of the population that then needs it the most that then could say no because of the concern over that additional copay. I think that is something that we need to watch very carefully and continue to advocate for alternatives around, and how we can support patients in continuing to have equitable access, regardless of the ability to pay for that portion of navigation, because we've never done that. We've never charged patients for navigation until now. That's a very new thing, and something that doesn't sit well, I'm sure, with many of us, is how are we going to, as a navigator, if someone says no to it when we know they need it, that's
right.
That's a tough thing of saying, okay, you're telling me you're declining it and we know it's because of cost, and how can we work to still support that patient, and how institutionally is an institution going to approach that scenario, because it's not going to be infrequent. And we need, I think that's something that we're going to really need to be paying attention to and quantifying to then determine what percent impact on the population that has.
I'm looking through, like, when the physician or the advanced practice provider recommends this is the treatment plan you'll be on, the patients aren't typically sat down with an itemized list of all those costs and then given the option to take it or leave it. And hopefully they would take it because that's what will hopefully, be in their best interest. But when you do have to talk about navigation in a very different way, as you said, like, if you're saying, like, do you want this? Might cost extra money. People who are already concerned about the financial impact of treatment, they might seriously consider ways that they can scale back and try to save their money. And so you're right. That's I think a big ethical, moral dilemma building of being able to present the information accurately and give them the information they need, of knowing what to expect, but also clearly emphasizing how important these services are, and just being able to justify that and explain that in a way a patient understands.
Yeah, absolutely. I mean, I still think back when my dad was told it was going to be $3,000 a month for his chemo pills. He was like, well, I can't do that. I'm just not going to do it. And so it'd be the same. I mean, I know that's one specific situation, but I just think about the people that they're already concerned about how they're going to pay for their cancer treatment. And then we're having a service that we know could help find ways to reduce some of those financial barriers. And that was what happened with us, was that we stepped in and we looked at different ways that the drug company could work with them on it and be able to provide financial assistance but that happened through navigation. And if there had been the decline of navigation, there couldn't have been then the breaking down of that financial wall to then treatment.
But would it? I mean, could we as nurses not help? Not help, even if they didn't agree to navigation services, we would still find a way to help them. But again, that's the dilemma, right? Is that
exactly
helping them to understand at the end of the day, they will still receive the best care possible. But here is what this navigation service will hopefully contribute in addition to what that best standard care possible is. And so that sounds like a bit of a pickle.
The institutions are going to need to plan for. We know that it's going to be an issue. We know that there is concern that patients will decline because of it. And so go ahead and plan for it and have that as part of your model so that then going into it, there's a decision that's been made that, okay, well, the organization will cover that cost so that there's not that then
risk
barrier. Yeah, exactly.
So Bonnie, tell us a little bit more about your role at the American Cancer Society and how does ACS support navigation? And are there ways oncology nurses can contribute to that?
Yeah, absolutely. So I joined ACS about a year and a half ago. I was coming from an academic cancer center and have been in the oncology field my entire career as either an oncology nurse or nurse navigator or behavioral scientist, and was brought on then to think about our navigation strategy and build out some key signature programs, which have now, ACS has been in the field of navigation for decades, going back to working with Harold Freeman as in the original 90s and funding navigation, developing navigation programs. Our role within this space has been consistent. And now we have truly the depth and breadth of navigation from a global perspective. So we have ACS Beacon, which is focused on building capacity outside of the United States. We have the American Cancer Society National Navigation Roundtable, which has been critical to building this evidence and bringing navigation groups together to advocate for even this final rule of being able to get to this point, along with, of course, ACS-CAN and their advocacy work, bringing navigation to the forefront and advocating for these changes. At the health system level, we have our navigation capacity building grants with 20 capacity grants across the country to health systems to build up sustainable navigation programs. Within ACS's community approach, we have ACS Cares, community access to resources, education, and support. And that's one of the programs that I was brought on to develop and launch. And we just launched in June of last year that has a patient and caregiver facing app that we've been very excited to help people who wanted to have a more digital experience in navigating their care from diagnosis, pre-diagnosis forward, and how they can then also find support through a community volunteer within the app and match based on a shared lived experience and be able to connect with the peer and talk about their experiences. And then we also built within the app a supporter quote role that we've heard from navigators, from other professionals, that they would love an easy way to be able to help find information for patients and caregivers. And so we built in a pathway for the professionals as well to be able to utilize as they're navigating so that you can go through and enter a patient's, where they are in their cancer journey, their different concerns. The screening tool built in is based on the NCCN distress thermometer and problem list, and really be able to help provide personalized recommendations for information based on their questions they may have or resources that they may be looking for. And so we wanted it to have across the board a tool that people could turn to in that moment of overwhelm or, in that I'm trying to do the best I can by my patients. And so I want a tool that then can support me and help keeping the process effective and efficient. So that's been something we've been very excited about recently launching, in addition to having student volunteers who can support in person. So we've had 3 pilot sites that launched in September that have student volunteers embedded within the healthcare system in the oncology, working alongside the nurses and the doctors in there, meeting with patients and providing an extra layer of support. So within systems that may or may not have their own team of navigators, but being able to just extend the reach of those supportive services and being able to identify barriers to care and help solve for them. And we're expanding that program to another 9 sites this year. And that's been an active process that we're really excited to be able to soon announce those additional 9 pilot sites. And then ACS Lion, which is Leadership in Oncology Navigation. It's our newest program. It's one that officially launched January 1st, but it's really in being responsive to this CMS physician fee schedule rule change and recognizing that we've had all this great evidence around navigation. Now we're moving towards sustainability, and how can we help standardize to the best of our ability? So one thing I want to make sure that we're clear on is, we want to have this solid foundation of navigation for those who are providing those services, but that it's always important to still customize. So customizing to the population, to the context, to the healthcare system in general. But if you start with that standardized foundation that then is based on the CMS rule, the competencies laid out there, based on the PONT standards, then you're able to further tailor your care, further tailor what the services that you're providing to the patient that the patient needs. But it's done so in a way that, across the country, CMS can say, okay, or, patients can say, okay, I know that I'm going to get this high quality care because these navigators or professionals have been trained in a standardized way. But then they're also going to be thinking about what I need as an individual because of that tailoring aspect to the training. And so ACS Lion is very forward thinking about that and how you have a standardized training, accounting for cultural differences, contextual factors, and then credentialing associated with that so that we can demonstrate to patients, caregivers, the providers, the billing practitioner has to attest that the person providing PIN services has been trained or credentialed or certified in those CMS competencies. So having the program have the credentialing aspect was important to us. And then as further part of that program, building out implementation support. We've been talking about all these different challenges, right? And how, yes, it's wonderful that we have these new codes and opportunities around them, but how do we put them into practice? And so we've been developing a series of webinars we've held live, and then they're available as a recording on our site for those that want to go back and watch those. And we're continuing to have those webinars across this year. Then also in April, we'll be launching a series of boot camps. So between the webinars where you can tune in and, learn about implementing the codes or, a topic that we've heard that is especially concerning, to the boots on the ground, trying to understand how to do X, Y, Z. What does this mean for me? Then you can also participate in a 4-week session where you're bringing your group together and making the case for navigation. So say you're in a system or at a practice that doesn't have a navigation team or a navigator, or, someone, you have people who are kind of piecemeal providing those services, but you want to bring it together in a way that's more sustainable and formalized and able to then be reimbursed for and that kind of thing. So really jump-starting the program and process through our boot camp. So we'll be launching our first series of that in collaboration with AONN in the beginning of April, and then continue to have a series of boot camps throughout the year just to make sure that we're supporting as many practices coming in as possible. We'll be having a financial toxicity learning collaborative in the fall because we know that that's a big big hairy problem for patients as we've been discussing. And so how can navigation and programs and practices implement navigation in a way that can reduce financial toxicity for patients, whether it's implementing a formalized screening process and doing it in a way. One thing that is like a soapbox of mine is screening for financial concerns in an ongoing fashion and not just at the beginning. Mm-hmm. Yes. Oh, it bothers me.
Finances change over time. They especially during cancer treatment. Absolutely.
Exactly. It's such an evolving, moving target. You can start out and be like, no, I think I'm in an okay spot, but then the bills start coming in and all of a sudden you're not. And if we're not continuing to reassess, then someone can get in trouble really quickly, financial trouble really quickly. And we want to be able to stay ahead of that. And there are so many resources out there. Triage Cancer is one that we, a group that we work with that's got incredible resources tackling these financial problems. That's the group that we'll be working with for this learning collaborative that will be a longer series. So the boot camps are 4 weeks long and recurring. The financial toxicity learning collaborative will be over 6 to 9 months, and we'll have a different cadence, a smaller group, and really tackling one problem versus building up the business case for navigation. So we're really trying to think through whether it's the one webinar at a time or a grouping of series at a time, whether it's the 4-week component of a boot camp and getting started or a longer tackling of a larger singular problem. How can we support the implementation of high quality, sustainable navigation? So I know that was kind of a long-winded answer, but we're just doing a lot of work in this space that we're really proud of and really wanting to think about how we're working with other organizations who also care about this topic, about this space, and about our patients and how we can have the best care possible for them.
Absolutely. It's like I think about when your doctor tells you need to exercise. Okay, well, how? Tell me how. It's the same thing. Like we can say you should have navigation, but the how is really important and really challenging. You touched on it exactly, and it was right where my mind went. It's that for programs that are still trying to make that business case and go to their leadership and to say, this is worthwhile, being able to have all of these great resources, operationally support them to how do I stand this program up? What am I measuring? What should I be looking at? And how can I also justify to my leadership that this is the supportive resources I'll have. Here's what we can start as our structure. Just to have those things can just go such a huge way. And I also would think, even if you are lucky enough to be maybe a single navigator, so you don't have a whole department, but you're N of one at your location, having these resources to help build that case for creating a more robust program or expanding the services. I think the reality is that the reimbursement is certainly welcome and overdue, but likely won't cover every operational cost that's needed for these types of programs. So you still will have to be able to continue to justify and make that case. And so all of the resources, the training, the opportunities that ACS is setting up to help make individual navigators and, entire programs successful is certainly very critical.
And I love the opportunity. So I'm a very practically oriented, how can I provide or how can we develop through the knowledge that is out there already, very practical tools. It's like bringing together the evidence to then put into a template or a checklist or a toolkit that can then make someone's job that much easier to demonstrate the return on investment, the measurement, as you were talking about with the metrics, that they can then focus on the patient care without then having to take away time to demonstrate how well they're doing, that we can provide those tools to make that part easier.
Absolutely. Well, and ONS and ACS have had a long history in just the general oncology sphere. So how are our organizations working together now to support nurses and non-clinical navigators?
That's one thing that, as still being somewhat new to ACS, I was really excited about as being an oncology nurse. And now my two worlds are coming together with ACS and ONS. And I think this is a perfect example of getting the word out. How can we amplify and share about this news that there is this reimbursement pathway, that there are options for both clinical and non-clinical navigation, for SDOH screening, for caregiver education? I mean, that's another really exciting development of being able to provide caregiver education and being reimbursed for that. And then community health integration. So getting the word out, helping people raise the awareness that this is now an option and that there are trainings, tools, resources available that then we're working together on through a webinar series of how can we make sure that we're providing webinars that are relevant to our oncology nursing professionals that are out there trying to then implement these new workflows. Those are things that we've been just very excited about with being able to work with ONS on and other educational offerings. One of the things that ACS is committed to is continuing to keep our training relevant, updated year after year with having annual refreshers, having curriculum that is responsive to, we know the oncology field landscape is ever changing, right? So how do we stay abreast of that as professionals and working with ONS to make sure that we're keeping all those hot topics infused within that curriculum in a way that is practical and meaningful for the professional, then needing to digest that information and then run with it. ONS is a fabulous partner with that.
Oh, that's wonderful. And certainly excited just for all the changes, the positive changes that are happening in the navigation space, and recognizing that nurse navigators have a very distinct role and domain, but there's enough work for both non-clinical navigators and nurse navigators to work together, to collaborate, to share the load. Because again, ultimately, it's what the patient needs, getting them the care that they need. The more hands, the better.
Oh gosh, yes. So much to go around.
Well, Bonny, it's been wonderful talking about you. I love talking about navigation. And, I think our listeners have learned a lot about these recent developments. So as we approach the end of our episode, we'd like to always run through just a few of our quick questions to help summarize some of the main points that we've talked through. So to start that off, how can healthcare professionals evaluate their hidden or implicit bias concerning patient navigation?
I think this is such an interesting question, because one of the things that, and it goes back to just the structure and the way programs have needed to evolve and develop because of inconsistent or lack of funding, is that not everyone gets a navigator. And sometimes that is decided purely upon, I look at someone and say, I don't think they need a navigator. And that's what worries me, is we can't just look at someone and assume that they don't need navigation. Truthfully, everyone could benefit in some way, right? But I think that's especially where our hidden biases can come into play if we don't have a routine screening in practice. That's the good thing though, right? Is that there are tools and procedures for having a standardized screening and tool to evaluate and assess patients of whether or not they feel like and would benefit and accept navigation at that point in the cancer journey. And that's something that, again, we were talking about similar with financial toxicity screening, but overall screening for navigation needs to be repeated over time. And so that's how we're continuing to keep our finger on the pulse of, is this patient running into barriers? Are they having concerns or questions about their treatment plan or symptom management? Or, how are we continually assessing where they're at in the process and not just looking and saying, oh, well, they look okay today.
That's a great point. I love that. What are some common misconceptions about patient navigation?
I think that varies from audience to audience, because I hate to say it, but I think it's the need that not everyone realizes, especially if you haven't been in the healthcare system or been a patient yourself or, gone through that journey with someone, that there is a need for this service. And I think it's becoming more and more recognized as we're publishing more, as we're advocating, and through this change, the reimbursement changes, recognizing that. But there's still questions from private insurers, from other groups where it's like, well, is it really needed? And so I hate to say it, but I think that's part of the challenge, is making sure that everyone recognizes how needed it is. And, it goes back to our boot camp of being able to build the business case for groups that don't have a navigation program yet, and being able to make it easy to then show the impact that it'll make.
What's something about this topic that's not often discussed, but you wish people knew more about?
I think it would be that navigation is needed across the continuum, including as someone transitions off of active regular treatment. So just because someone is no longer needing to come in every 3 weeks for chemo or daily for radiation, like there's still a need for education and support. And again, going back to programs having to pick and choose how they implement navigation, oftentimes we would see that navigation ends when active treatment ends. And there's that very distinct drop off that patients experience when they are transitioning back to their primary care and just feeling like they're losing their entire oncology team and people they've really trust and gotten to know, depended on. And that's the same is true for the navigator, and how important it is for the navigation services to extend into survivorship and to cover the full continuum of care.
My hot take is that it's the most important place to have a navigator. Survivorship. Just thinking of helping them to continually, surveil for recurrence and, all of that. You're absolutely right. So I agree 100%. What additional training or education do oncology nurses need to stay current about navigation?
For one thing, I think both ONS and ACS are putting out great resources, educational offerings, whether it's through webinars or boot camps or our online resources about the changing field, how the CMS rule has changed, how we can have new tools that come to light and that are developed based on as people are starting to put these codes into practice, that really looking to their professional organizations and to their peers about how are you doing this? How is this being done with this group? And that's something that ACS would love to continue to hear from folks about, is what are your experiences as you're defining your workflows for implementing these codes, as you're actually having those cost sharing and consent conversations. We'd love to hear from folks about that so that we can continue to provide responsive information and educational resources to address those questions.
What are some additional resources maybe for patients or healthcare providers not in the oncology space who want to learn more about navigation?
That's another interesting point because so it's two different audiences, right? And so when I think about from the patient-facing side, ACS Cancer.org has wonderful patient and caregiver-facing resources. We do have a section on navigation and what can a navigator do for me? How does that fit into my cancer care? And so I would certainly point patients to that resource. There's, from a healthcare professional standpoint, the ACS National Navigation Roundtable has pulled together amazing resources across the field of navigation. And I know ONS has as well. And so there's certainly educational resources for those that are maybe not actually delivering the navigation services, but are still trying to understand how this is impacting their practice. And similar with ACS Lion's implementation support programs as well. You know, that's really the audience that we want to serve, is across the board people who are impacted by navigation, who are implementing and trying to support navigation.
Absolutely. Well, as you mentioned, so many resources available both through ONS and ACS. And so we'll be sure to link as many of those as we can in our episode notes. Bonnie, thank you so much for joining us today. It's been a great conversation, lots of important information that I think nurses are really interested to hear about as the navigation space continues to evolve and get the spotlight that it has so long deserved. Do you have any final comments to share with our listeners?
I want to thank you and ONS for the time to be able to come and talk about this important issue that we're both clearly so passionate about. And also just to ask that listeners feel free to reach out to us at acslion@cancer.org or check out our website. So cancer.org/lion to be able to connect with us and learn more about our professional facing navigation programs and trainings.
Wonderful. Thank you again, Bonnie.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.